renal pathology, renal cancers. Okay, so for the kidney cancers, the number one highest yield one is going to be renal cell carcinoma, and that's what we're going to be covering majority of today in this audio clip. But I will cover all other kidney cancers that are, I think, high yield. Okay, so first and foremost, I said renal cell carcinoma is the most important thing that you have to know. Okay, so first and foremost, it's going to be clear cells. Okay, and that's why another name for renal cell carcinoma is clear cell carcinoma. And the reason that they're clear is because they're filled with lipids and carbohydrates. Okay, that's something that a question that they usually like to ask. It originates from the PCT, so the cells originate from the proximal convoluted tubule, and it invades the renal vein, okay, going into the IVC and then causing a hematogenous spread. Because remember, carcinomas usually spread via the lymphatics, but this is one of the exceptions. The renal cell carcinoma is an exception that spreads hematogenously, and it metastasizes to the lung and the bone, okay? And when it metastasizes to the bone, it causes osteolytic bone lesions. Okay, this is one thing that you have to know. Osteolytic bone lesions are seen with renal cell carcinoma when it mets to the bones, okay? And that is seen in other pathologies as well, which we've discussed previously, but that's one that causes osteolytic bone lesions is renal cell carcinoma. Okay, so you can see back pain with osteolytic bone lesions when renal cell carcinoma mets to the bone because it spreads hematogenously. Now, the patient is going to have flank pain, a palpable mass, and hematuria. That's a classic triad. Okay, and what they love to ask, okay, is its associated paraneoplastic syndromes. And what paraneoplastic syndromes are essentially secondary syndromes, okay, due to the fact that there is this cancer that's secreting these things out of nowhere, okay? So renal cell carcinoma secretes PTHRP, which is just another form of PTH-related peptide. It's also going to secrete ectopic EPO. It secretes ACTH, and lastly, it secretes renin. So question stems like you to know that renal cell carcinoma has this paraneoplastic syndromes that secrete these four things and can lead to these paraneoplastic syndromes, okay? Now, a very high yield associated risk factor is going to be smoking. Okay, smoking is the number one risk factor for renal cell carcinoma, so be aware of that. All right. Now, it's associated with VHL, and VHL is a tumor suppressor gene. Okay, so when VHL is lost, you have an increased risk for renal cell carcinoma. It's found on chromosome 3. Okay, renal cell carcinoma, chromosome 3 associated with VHL. Very high yield, very important to know. All right, so I'm just going to kind of run through this really quick just so that you can understand it. Renal cell carcinoma is going to be originating from the PCT. It's filled with these lipids and carbohydrates, hence giving it its name, clear cell carcinoma as well. It invades the renal vein and travels via the IVC hematogenously, so unlike other carcinomas, and it metastasizes to lungs and bone, causing back pain with osteolytic bone lesions. The patient's classic triad is flank pain with a palpable mass and hematuria. However, that's going to be very difficult to kind of pinpoint, so you got to know these specifics. And the paraneoplastic syndromes associated with it is the production of PTHRP, EPO, ACTH, and renin. The highest and number one risk factor for renal cell carcinoma or clear cell carcinoma is going to be smoking. And it's highly associated with chromosome 3, VHL, and the loss of this tumor suppressor gene. Make sure to know what it looks like on histology, on gross anatomy, and on x-ray. Very high yield. They'll ask about every single one. All right. Now that's all for renal cell carcinoma. I'm going to ask for the next one. I'm going to be talking about nephroblastoma. Nephroblastoma, another word for Wilms tumor. Wilms tumor is the most common renal malignancy in children. Okay. So kids have this. And the main question that they're going to ask, or kind of not question, but the way that they're going to present it so you know that it's Wilms tumor is that you're going to see a mom like washing bathing her kid, and she notices a large, palpable, unilateral flank mass. It does not cross the midline. The patient could have hematuria, okay? And it usually can metastasize to the lungs. Now, what the question they'll ask is the hallmark cell of nephroblastoma. The hallmark cell of nephroblastoma is the blastema, okay? Very easy. The nephroblastema is the hallmark cell, all right? Now, nephroblastoma or Wilms tumor is associated with chromosome 11, okay? And that's where you're going to see WT1 and WT2 genes on there. Okay, chromosome 11. And it's a loss of function mutation of tumor suppressor genes, of those tumor suppressor genes specifically, WT1 and 2. Now, they're a part of other syndromes. Honestly, the other syndromes aren't really that high yield. The only one that you can mainly see is Wagner complex, which is Wilms tumor. You could have the absence of an iris, which is aniridia. You can get genitourinary malfunctions or malformations, and then you get a range of developmental delays. All right, that's pretty much all of the important stuff for renal pathology. If you have any questions about the kidney, please let me know.